Good morning. My name is E.Czerwinski. I am Professor Emeritus of the Jagiellonian University and Senior Medical Director in Future Meds. I have been acting as orthopedic surgeon for the last 53 years. I'd like to present to you medication-related osteonecrosis of jaw, what is a recent problem which we met in the osteoporosis treatment is there is a big trouble for patients and doctor, however, is very rare. In this presentation, I will present the pathogenesis and the risk factors, medically related ONJ and osteoporosis treatment, what is the relationship, ONJ treatment itself and prevention, and then summary. So, oral cavity is a difficult situation in real life because we have a lot of bacteria, 800s, and we have our jaw, a bone of the jaw with this cover with a very tiny gums, and at one point the gums is end of the gums and the hard tissue. So this is the barrier for the microbes, because if they get through that, they may develop infection. But periodontitis, of course, increases that risk. So you have an osteoporotic jaw with weakened immunity caused to antiresorptives or other agents because they decrease bone remodeling and angiogenesis. So if you have the blood disruption, perhaps from the infection is the first cause, but some says that the necrosis is the first step, so it can develop the ONJ. The more frequent cause is the surgery on the jaw, maxilla, tooth extraction or implant insertion or denture stomatitis. And please look on the socket after the tooth extraction. Is it the open wound with the bone inside? So for my orthopedic classification is a compound fracture when a bone is taken from the soft tissue. So that's the very, very high risk for inflammation. So we have an elderly patient who has osteoporosis. Aging causes periodontitis, inflammatory process, and osteoporosis. It is a quite complicated process which leads to tooth loss, periodontitis, and you see quite similar action like in osteoporosis, what will accelerate that. What are the risk factors? The patient, surgical procedure up to 70%, periodontal diseases, denture, smoking, general cancer, osteoporosis, general health status, I think gens, diabetes, and steroids and rheumatoid arthritis. Medication, I put them in the order on the highest risk because the more potential antiresorptive, the higher risk of ONJ. It is like you are driving your car very fast, so you will reach the goal very quick, but you put yourself at the risk of the accident. So we have in the order the denosumab, IV zeledronate, IV ibandronate, risedronate, PO ibandronate, arendronate. And unfortunately also cancer medication with patient cannot avoid them in some cases. So have imatinib, sunitinib, and bevacizumab. The worst scenario is if the patient will be on both. Fortunately, there's good news that the bone-forming agent are not the risk factors, non-case on teriparatide, none on the baloparatide, and just one over the years in romosumab. So I think it's just an accident. The pathogenesis is very complicated. There is a lot of publications with cytokines, as you see, quite very advanced analysis. And what is the summary of that there are patients who are at risk and may have the MRONJ and those who are resistant. So it is kind of relative because unfortunately we don't know which patient is in our surgery. The definition by American Association of Oral and Maxillofacial Surgery is that the diagnosis have to fulfill all three criteria, mean the treatment with antiresorptive, or as I said, the combination with immune modulators or angiogenetic medication, exposed bone, I mean direct exposed bone, or accessible to the fistula. It persisted more than 8 weeks, and no history of radiation, because we know that radiation itself can generate bone osteonecrosis. The symptoms which we should tell to our patient, so either stage 0 or 1, something is running in the mouth, means pain, swelling, loose teeth, infection, ulceration of the gums, numbness, or fistula. What is a good news that 50% of those symptoms cannot progress to the further stages and can be prevented. And we have just here the swelling. So our advice to the patient who is on our care, that anything you notice in your mouth, go to your dentist and tell him, and she will knows what to do. So as the classification from stage 0, 1, 2, and 3, I will skip that. So here we have the bone necrosis, a huge one. Some of these cases have to be operated, unfortunately, and treatment can last even months, but usually on the very, very end, there is the happy end. However, there are some very complicated cases. So how it is with the osteoporosis treatment? First of all, our trials. So we have 35 cases after 10 years in freedom, 9145, non-interiparatide, non-abaraparatide, just one on frame, one gives on 1,000th. In failure stages, where we have the denosumab, we have 2 non-denosumab in ARCH study, but one will swap to arendronate and to andronate group. In real life, placebo got 200s because they got osteoporosis, bisphosphonates up to 500s, but there is a report that it could be even 3.4% in 55 years old. Denosumab, even 2.2%. As I told, none on PTH, none on abaloparatide. In the population, you got the numbers, what I don't feel very well, but what the crucial information that in stomatology, after the procedure, in osteoporosis, there is a risk of 2.3, and in malignancies, 5.3. Very educational publication of Judy Divergabe. 3,000 patients, roughly 3 years of treatment of bisphosphonates or denosumab, and altogether 17 patients, meaning over 2/10 of patients, 2.8 in the denosumab group, and 20 or 3 tenths in bisphosphonates. And please note that the cases are the denosumab, the cases are just below the 5 years, usually after bisphosphonates is over 5 years. So the message is that in denosumab, the risk is higher, and we had two patients, a woman who developed ONJ just after the first injection of denosumab or generic. We don't know which one, but I think doesn't matter. Here you see the more drug activity in the elderly patient, the higher risk. Here you have a percentage of MRONJ. Here is 5 years, and here is the curve of bisphosphonates, and the curve of denosumab, much more higher, and it goes even higher over the next years. A good message is also that in FDA reporting of ONJ, we see that we have a very big number in 2015 or 16, around 2000, and now is almost 10 times less in 2021. So I mean that prevention works. What to do if you have a patient who or she will have a surgery, I mean unexpected tooth extraction or planned tooth implantation. So there is discussion, should we stop the medication? Doesn't matter. And here we have that doesn't matter at all, whether we stop or not. However, and major papers stated that. However, in the recent ASBMR, it is a publication of very huge number of the extraction that a break for zoledronate to 6 months reduce half, and the same in ibandronate. What is difficult to understand why is no higher. So the Polish Dental Association says that you should discontinue bisphosphonates 3 months before and 3 months after. However, American Association of Oral and Maxillofacial Surgery say that there is no evidence, and in fact it could not work because no one can expect that you stop bisphosphonates even half a year, it will really change the bone metabolism. We know that it is frozen for years. And the same in denosumab. I haven't found publication how is the relation between the rebound effect and jaw osteonecrosis. I think it could decrease. It could, but I'm sure there are some studies on which perhaps I couldn't find, but we look for. So the treatment is the area for dentists, not for us, but just in stage 1, we have optimal hygiene of the mouth, elimination active diseases, eventual local antibacterial rise with chlorhexidine or systemic antibiotics. And stage 1 could be considered as a potential precursor. It was in this publication of Raggio. I will not discuss the issue of kind of surgery. Dentist knows it very, very well. So, recommendation for patients to prevention, recommendation for patients, first education and information that there is a risk. In case denosumab is the must on the first visit. It is not easy sometimes, but fortunately patients are usually prepared and are very afraid of. If you have bisphosphonates, I put this patient, say, in the next couple of visits, no rush. Oral hygiene, instruction of early symptoms, I mean, whenever is going in the oral cavity, go to your dentist. Prohibited smoking, absolutely. Fluoride, toothpaste, and eventually before denosumab, absolutely dental examination. Or I asked patient if she was just in her dentist 2-3 months. I can accept that the risk of surgery is very, very low. So summing up, the weakening of the gum-mandible barrier and its resistance to infection is the key to development of medically related osteonecrosis of jaw. Surgical procedure is the major cause, approximately 70%, and osteoporosis itself is a risk factor because it increases the risk of periodontal diseases. In addition, antiresorptive reduce the resistance due to slowing down bone remodeling and inhibiting angiogenesis. The more increased drug activity, the higher MRONJ risk. Incidence is of placebo 200s and bisphosphonates up to 500s, denosumab 2.8%. Average time of occurrence is 2.3 years, but in case of denosumab, it's very, very early, even after the first dose. And the incidence increases with age. Initial symptoms in stage 1 are pain, swelling, conjunctivitis, heavy jaw, and so we relate to the dentist, it is no our business. 50% of stage 1 recover, so the education of the patient is crucial. Dentists are very, very aware. Maybe they even sometimes exaggerate, but it is understandable. Polish Dental Association recommends a 3 months drug interruption before the procedure. However, American Association consider there is no clear evidence, and I think really there is no. What I do, I advise to break, to make patient feeling that she can do something against. I will never say that doesn't matter because she is frightened. I think that kind of patient good is acceptable. Prevention is the key. Oral hygiene, fluoride toothpaste, dental consultation, and no smoking. So, thank you very much. for your attention, and I'll be happy to answer any question. You can write on my Academy of Osteoporosis, YouTube, or somewhere else with answer. Thank you very much.